Hello, I'm David Scharf. I'm co-chair of the American Psychoanalytic Association's COVID Advisory Committee, an analyst in Washington, D.C. So we've assembled a small group of us to talk with you about the issues in this phase of the pandemic. And I'll ask each of them to introduce themselves. Dan?
Hi, I'm Dan Prezant, acting co-chair of the APsaA COVID-19 advisory team and a psychoanalyst in New York City.
Jennifer?
Hi, I'm Jennifer Lane Briggs. I'm a psychoanalyst in private practice in Miami, Florida.
And Jeff?
I'm Jeff Taxman. I'm a psychiatrist and psychoanalyst in Milwaukee, Wisconsin. And I have a particular interest and experience with working with first responders during massive disasters.
And Gail?
Hi, I'm Gail Saltz. I'm a psychiatrist and psychoanalyst in New York City, and I serve on the Public Information Committee for APsaA and do a lot of public education and media work.
Well, thank you all, and thank you for being with us. So we're going to have a dialogue and a multi-log about these issues of this phase of the pandemic, and we're going to consider several topics. And the first one that we thought we'd take up is to open up or not to open up our offices. That's the question, a question which highlights many issues and possibilities, and Dan Prezant is going to lead off.
Thank you, David. So this is an easy question with an impossibly hard answer, because when COVID hit the world, it was easy to know we had to close our offices quickly and react overnight, and there wasn't a lot of choices about it. Took some of us a few days, but pretty quickly we all closed our offices and knew what to do. We had to protect ourselves, our patients, our families, their families, and really everyone. And it was the right thing to do. It was an emergency situation. We responded. Now it's become a lot more complicated. When there weren't vaccines, when the incident rate was very high, when the disease and death rate was very high, it was still simple. Stay closed, be remote, work on Zoom or some other platform. The closer we've gotten to terrific vaccines and high vaccine rates and the disease, getting under control, fewer hospitalizations, fewer deaths, it's now much more of an open question. What do we do? There's not really a blanket answer for that, except to maybe first begin with realizing that people like certainty. They do not like uncertainty. We as analysts and therapists, dynamic therapists and others, would say that in many ways, uncertainty is good. We value uncertainty in our patients when they often don't. But with this, I think both therapist and patient want to be certain, either open or don't open, either get vaccinated or don't get vaccinated, either see this kind of patient or not. There is no easy answer. No one should feel pressured into opening or not, or seeing certain kinds of patients or not. Everyone really needs to make their own unique decision and feel comfortable with that decision. That's easier said than done, because there are pressures on us. People, patients, our families want an answer, and they want the right answer. There are insurance pressures on us that insurance may or may not cover certain practices or may cover it less than we would like to see.
Gail, do you want to come in on this?
Yeah, I think that what's been interesting this year is how many practitioners have found more efficacy in telemedicine than they ever expected. And there have also been a lot of studies that have looked at efficacy as much as one can do a study in this setting, and found actually that many patients are benefiting from telemedicine, often just as much. And that has been a big surprise. Certainly psychoanalysts, I think, are one of the least optimal populations for practicing telemedicine because of the way we practice. But I think many psychoanalysts have also found that, in fact, they have been able to see patients and have been efficacious in doing that. And I think that will play a role that we don't know, to be determined in people's decisions about coming back. Some patients may continue to be comfortable because that's what they've been doing for a year. And some psychoanalysts may continue to be comfortable because they found that, in fact, it works.
Yeah.
And that means being flexible in a way that isn't typically historically true of psychoanalysts, being, hey, this is a new frontier. We've introduced something different. Turns out that it may be efficacious. It may not be for everyone. There are plenty of people who may really prefer and feel that it is more effective to come back to their office, but that may not be everyone. So we're going to have to potentially embrace differences in the comfort level of our patients and in the comfort level of our practitioners of what is gratifying for them in the work, what they feel is effective in the work, and what patients will be comfortable and tolerate in the interaction in either the office versus telemedicine. So I think we just have to be open to various possibilities.
Good
Gail,
thought.
that's an excellent point. I think if the practitioner and or their patients believes in telemedicine, believes in working online, they have a lot less pressure to go back. If they or their patients don't find it useful, then there's going to be a lot more pressure to go back.
Although, Dan, you talked about uncertainty and certainty in the office. And one of the reasons we clinically like to allow uncertainty is the appearance of certainty and the desire for certainty is often used defensively against anxiety and fear. And I think for a lot of clinicians, even Gail, when you mention the studies, I think sometimes we are also clinging to certainty about I can't open the office, I can open the office, as a way to avoid the ambiguity and uncertainty and fear. And I think we have to be careful to allow our own judgments and feelings about our safety to be discussed and weighed.
I do think a fundamental issue here is safety. And I think there's more than one kind of safety. We have become more physically safe with the vaccine. We look to the CDC for guidance. And so based on CDC, what CDC says, it is physically safe for us to be seeing people that are vaccinated. But there's a different kind of safety. That's emotional safety. And that's the gist of what we do. That's the core of our work. And as far as opening or not, if we don't feel emotionally safe, either us or our patients, then reopening might not be the right choice at that time. And that's going to take an evolution, because really for a year, other people in a way were dangerous to us. And even though things have come along, it may take a while for that feeling to go away. And so I think that needs to be a very important piece in people's decision as well, is when they feel emotionally safe.
I agree with you, Jennifer. And I think now we're facing this question as there is a kind of pressure in general to open. As the CDC says, yes, people who are vaccinated can be unmasked and in a room together. At the same time, people may not feel that way and may be facing their own fear of their patients without certainty about their situation and feel under pressure at the same time from some patients, from their situation, from insurance companies that may be giving less reimbursement for telemedicine.
Well, David,
all of those things. Yeah.
I think you hit it on the head with facing our fears. We have been trained and have experience to look inward and have introspection about where our fears come from, whether they're rational and reasonable or they're driven by something else. So I think facing our fears about opening or not, about our patients, is what we need to do just like any other situation in the analytic setting, and assess them and think them through.
And I think that's a really hard thing to do. I think many of us throughout all of this and throughout life, but this in particular, we struggle with, are we being kind of hysterical in our reaction to this, overly fearful? Are we being realistic? Are we being phobic about being out there in public and out there in our offices and showing our bodies? Many of us have gained weight or something over this year of more privacy and Do we have a certain phobia that's keeping us out? And then it so to speak, it ain't so easy to always know what is realistic, both because of our fears and, many of us would have a year or two ago would have just listened to the CDC or the New York Times or these respected sources. With so many perhaps miscommunications, changing science, a lot of politics, pushing it one way under, one administration and now maybe another way under another administration, with a pressure to shape things, to push people to encourage to get vaccinated. If you're not going to change your behavior with a vaccine, why bother? So the end result is that many of us wonder what to trust, who to trust.
Yeah.
I was going to say, really, this is a unique situation where what we're talking about for psychoanalysts mirrors the public in general, that everybody is struggling with a year and a half of having made the biggest behavioral changes that probably any of us alive have ever made as a nation. And that was created and enabled by fear, by anxiety, by the realization that, perhaps our lives are at risk or our loved ones' lives are at risk, that caused us to make these enormous behavioral changes that were then reinforced cognitively by the relief felt at being safe in making those changes. And that takes time to undo. It's sort of like, I realize that we want to analyze that and we want to understand past fears that may dovetail with this and complicate moving on from it. But at the same time, there is a certain, cognitive behavioral reinforcement that's gone on that will take some exposure and time to make these movements. I think that it's difficult when we're trying to analyze something for our patient that we also have to analyze for ourselves. And it's a unique experience, sort of like when when I was pregnant, and treating patients, it's a reality.
Well, I think we've had some very excellent points about whether to open or not and all the issues that it leads to. So thank you all very much for that. And we'll turn to our second topic, which is the nuts and bolts, the practical considerations about reopening and what kind of models we're going to use. And we'll turn to Jennifer to open about this.
I recently have reopened my office right now, just a case or two. And these are some of the things that I've done that I hope you'll find helpful. I have actually framed my vaccination card, just like my license, and put it up on where people can see it, because I do think that does provide a sense of safety. And I do think that our patients have a right to know. I covered up my birth date, though. I'm all for self-disclosure to a point, I am also asking them to bring a copy of their vaccination card for a sense of safety, and a trust really hasn't been a problem because they seem relieved, because they also know I'll be doing that for everyone else. So there is a sense of safety, I think, that can be in that. I purchased a HEPA air filter with a UV sterilizer that I run, and I have that out in the room. I have masks provided for anyone that for any reason might feel unsafe, antibacterial gel, antibacterial spray. I don't use my waiting room right now. I'm having people let me know when they're ready. I let them in, I open all the doors, and it has been an adjustment to start seeing people again in person. But I do think that these are some of the things that I have found helpful. And have seemed to work well with the people that I'm seeing. And I view it as a slow rollout. I do think that some people are happy with telehealth right now for their own reasons. But for me, this has been an effective way to start.
Good. Thanks, Jennifer. Others?
Those are very good, Jennifer. Thank you. The only thing that I add in that, because I have been seeing some people, is I personally am very comfortable taking my mask off if I know somebody's been vaccinated. And before I do that, I will ask the patient if they are comfortable or not.
I forgot to mention that, yes, I am seeing people without a mask if we're both vaccinated. But I think you bring up a good point about asking.
Well, this is a problem, isn't it? Because if you see somebody with a mask, there's an awful lot you don't see.
Exactly.
In some ways, you can see much more in a Zoom session when it's not impeded by a mask. or by the anxieties of being in the room.
I would say, just to a practical point, here in New York City, rents are very expensive. And I am very aware of many people having basically stopped using their office and stopped, their lease, because it was an indefinite amount of time that people would be Zooming. And so it's a big decision. It's a very big decision to then come back to an office. It's not just a matter of coming back to your office. For many people, whether to have an office, whether to open their office, I think is a big decision, and a realistic decision. We have to take care of ourselves in addition to our patients. And along that line, I think we also have to grapple with the fact that we're mental health professionals. And I think that obligates us somewhat to follow the science, to be representatives and role models of following the science. And I'm aware that that seemed murky at times with the CDC over the year because it got politicized. But the reality is we're under a different administration, and the CDC is working, I think, very hard to follow the science. And there are papers available you can read. You can look at what your local hospital is doing, other kinds of healthcare providers are doing. And it's important, I think, to model for your patients following the science.
Yeah, Dan?
Yeah, related to some of what you've been talking about, which are all excellent points, the kind of office you have, I think, also affects this. If you have an office in a suite of offices, if you're in a clinic, if your office is in your home, you're going to have different feelings and different exposures. If your office is sort of in a big office building where you're sharing bathrooms and elevators, the risks are different than, let's say, you're in a rural area and you have a standalone building that you see patients in, and your patients can sit in a car no matter what the weather until you kind of text them to come in, as opposed to city patients who are maybe walking or taking mass transit and standing outside or in the snow until they can come in. All of those things are going to have effects. And all of this, I think, affects our practices in terms of how, as analysts and therapists, we're often trained not to be directive with patients, not to tell them what to do, what is acceptable and what isn't. We want to encourage them to kind of have agency and speak about and whatever it is they want to. This pandemic and reopening our offices requires, I think, a much more directiveness than many of us are comfortable being.
Yeah, I think that's a point that I take seriously, that these are management decisions. These are not analytic decisions. Of course, they have analytic consequences and are to be explored, but it is incumbent on us to make the practical decisions that ensure safety to the extent we can. And something that Jennifer's talked about, the emotional safety of both parties. Jennifer, you wanted to say something?
I just wanted to echo what Dan had said, also to the core of this being a very personalized decision for therapists. My office is individual. I have a separate door. I don't have to run into other people. And so there are freedoms that I could take that somebody in a different situation might not be able to take. So I think it's just very important to recognize how individualized this is, and how there are many, many different ways to do this successfully.
To underscore that, David, as you know, I'm in the Midwest, and many of the analysts and psychodynamic psychotherapists that are my colleagues and my own office is in a clinic setting.
Yeah.
So for many of us, it's not just a question about one person in the waiting room or my individual patient. And I think a lot of us are worrying about that in addition to all of the individual in-session decisions and fantasies.
Yes, I think that's important to stress that. Okay, Jennifer's in one situation where she has total control of her office. You're in a situation where you don't and can't. And for us to really try to be thoughtful about everybody's varying situation and the complications that they are. And I think these nuts and bolts issues will come up. One that we haven't mentioned so far is really the question of hybrid work. I think it follows from something you've said, Gail, about how people are finding that they like working remotely in these ways. Both the therapists and analysts and the patients may like it. And the question of what will it go back to? Will people say, you know, this is working just fine for me? I'm thinking about from the patient's point of view. And I don't really want to come to your office 4 days a week and lose the 4 hours of commute time. What can we do instead? I'm thinking, for instance, for an analytic patient, well, it may make sense to maybe meet in the office 1 or 2 days a week and remotely other days of the week, or some kind of hybrid situation. Never mind those people for whom actually they're traveling, so that they are going to work in telemedicine, teletherapy kinds of ways. I mean, I've actually been doing it for many, many years. I have patients who are in distant time zones or who travel frequently for work. So I'm quite convinced that for many and maybe in most patients, it really is effective, but it isn't effective for everybody. Yeah, Jennifer.
I think tied into that is maybe looking at resistance in a different way, because I think before the pandemic, we might have viewed these issues as a resistance. And I really think that we have to rethink that. The practicalities of being able to carve out 45 minutes for someone who's, for example, a partner in a law firm, you know, that gives them the freedom to be able to really be there on a consistent basis. And that's their reason for not coming in, is really quite different. And so I think it's changed my idea about what not coming in means. And it's something that we should all think about.
Good, Dan?
Yeah, I think the hybrid model is really a very important part of all this. And for many of us who see patients back to back, it will be a very interesting question as to how we manage the practice and deal with the patients. So are we going to interpret patients, as Jennifer's saying, resistance to not wanting to come in person as, you know, not opting for the best, so to speak, treatment? Are we going to set rules about it? If we have patients who say, whether it's a rule or not that we set with them, that they just want to come on Zoom, what if they show up one day in the office, or a patient who's supposed to be showing up all the time? That's the agreement they've made with you. And at the last minute, they call and say, well, I couldn't get there, so I'll talk to you on the phone or on Zoom. How are we going to manage that at the appointed time, so to speak, of a particular patient's thing? Do we go to the waiting room? Do we turn on the computer? Do we turn the ringer on the phone? Or do we turn some of those things off? And are patients going to want to kind of catch us with our pants down, so to speak, in a primal scene kind of thing, where they just pop in and see what's happening? It's going to be an interesting world.
Well, I appreciate the humor you've introduced here, Dan, and I think we've had some good things to say. So let's move on to the next question. The next topic that we agreed we'd take up was the vaccination complication. What do you say to unvaccinated patients? How are you going to require proof? Or what do you say to patients who are vaccinated, but you're not ready to see them? All those kinds of questions of risk, of your own risk, their risk, families, young children, all of these things. So Jeff, you were going to take the lead on this.
Sure. Yeah, the issue of seeing people in person and whether you wear a mask or not, depending on vaccination status, sounds fairly straightforward. The devil, of course, is in the details. Issues like patient choice and looking at it as just a clear-cut administrative, I'm going to see people that are vaccinated. Well, what about patients that may have issues of not being seen the way others are, sibling rivalry issues, issues of our own choosing about who we want to see, and whether it leads to potential countertransference issues that might be further hidden by our administrative decision. One of my other concerns about this is that this question comes from a rapid, almost explosive change in praxis for all of us. We've had to force change our practice, and there may be reasons that we want to see a change in practice as successful, a bit defensively, and it may affect how we decide whether we're going to go back to the old way of seeing people in person or not. If a patient shows up and they didn't bring the right purse and they don't have their card, are you going to send them home at the time of the session? If somebody says I've been vaccinated, or with all the snowbirds, people come back from Florida or from Arizona, they're not on the state registry. Can you check? Should you check? And I think that the vaccination question is very important. And of course I ask it, but it may focus us on a fear and anxiety role with our patient, and an adversarial role that is unintended.
Yeah, I think, Jeff, you touched on it. It's such a key factor of trust. There was always this sense that you and the patient, we were in this together. We were, and the patient's fears of hurting us or us hurting them was very much something in their head. It was a fantasy, it was a wish and a fear, and it was something that hopefully we could help the patient talk about, but with the understanding that in reality, they were not going to hurt us with their words and we were not going to hurt them. The pandemic threw us into a situation where actually we really could hurt each other and we really could hurt our families. And so how do you trust the patient, and how do they trust you? And this question of, do you have your card with you? It's not something we think of generally to ask. We don't, require them to wear the right kind of clothes to come to our office. So it has become a very complicated matter. And there are areas of the country where lots of people are not getting vaccinated. So if your practice is out there, it's different. And then there are, maybe the people on this Zoom are with, more analytic work with a few patients, but there are insurance people on panels who are getting an influx of new patients every week. These are people they don't know. How do they trust them to know if they're vaccinated or not? The vaccine cards themselves can be mocked up.
Sure.
So it's quite tricky.
Well, I think another point is, what about other patients? The CDC has said not only is it safe for vaccinated people to sit with other vaccinated people unmasked, but actually it's safe for vaccinated people to sit with unvaccinated people unmasked. It's safe for the vaccinated person. It's safe if you are the practitioner, it's safe for you. The question is really the unvaccinated person and the unvaccinated person together. And so I think, you can take on the responsibility for yourself of deciding you feel comfortable with unvaccinated patients, but if you really set up a situation that you're not putting your other patients who might also be unvaccinated at risk. And even if that's not the case, that material will come into the office. That will be part of the analysis, part of the fear that patients often have. Are you keeping me safe or not? And
Right.
And can I trust you to keep me safe or not? And I think, well, as we always say, that's grist for the mill, and needs to be understood. It would be part of treatment, but there is a reality factor.
I think something else, and this echoes what Dan was saying, is the idea that, what if we're working with someone that doesn't want to get vaccinated and engages in all sorts of risky behavior? We don't really have the full freedom to just understand it, because there is this physical risk. And so I think it's a very tricky thing, is how would one talk to a patient who wants to come in, but you feel because of the way that they're acting that they could very well become ill. And so again, I think there's this physical safety bit that hasn't been there in the past that we have to be very aware of. And there's no easy answer to it, I don't think.
Well, I think that actually leads me to think we've had these important things to say about this group of considerations, which are very practical and not simply matters for analytic understanding. They're really practical matters about safety for everybody, ourselves, our patients, and the people they're in contact with as well. So thank you for that. Now let's move to some of the practicalities and ways of thinking about some of our special populations. The one that really looms immediately is about children. So for those of us who see children, and in this group, Dan and I are people who see children, it's complicated because some children can make using an iPad or a computer part of the game that they're going to play. And because our focus with young children, play age children, is in the play, if a child can incorporate the computer and do computer games together or use a whiteboard together on the Zoom function, it can be just great and very playful. And grandparents have related to grandchildren who are across the country this way throughout the Zoom thing. And many of them have found that it's actually a way of being with their grandchildren they couldn't have imagined before this. And it's better than not having access to faraway grandchildren. But we've got these children. And some of them really can't manage in this situation. So I think of a child I heard about who would turn off the computer. So instead of being in somebody's office and hiding underneath a chair or something like that to indicate negative feelings in the transference, to turn off the computer, you're kind of stuck. Well, you can involve the parent and have a child and parent session and have the parent manage the computer, and that may be very effective. But it may also be an impingement on the privacy you might need with the child. Maybe having them in a conjoint session actually is a benefit and might be better, or that you can use family therapy for that child instead, which is a medium I like a lot. But these are special considerations. Some people have seen children outside if they have a protected outdoor space and it's not too cold or too hot. And that can be effective. I've done that. And it's really restored a therapy that was not working well remotely. But a lot of people are in offices that don't have access to that. So there's all of that, in addition to the question of, all right, how do we work with other ways of working analytically, groups and families? Family therapy, it seems to work really quite well on Zoom. People can be in the same room together, or they can be in their separate squares. And anybody who's used to running any kind of group on Zoom can do that. But it is different. Dan, you want to come in on this?
Yeah, so I mean, this is a fascinating area. You know, many of us would have thought that talking to children on Zoom was like 20 years ago, talking to a little kid on the phone, and it would be a very stilted, dead conversation that would sort of end almost as it started. It's no longer that way. I mean, little kids grow up with these devices, and some of them, their first words are iPad or iPhone. So the world has changed, as anyone who's lived through COVID well knows. But it's still, therapy analysis is different. And it's still hard to do this kind of work in a very free way with, with children. I think in some ways they are the patients who are most in need of in-office work and hardest to work with this way. However, that's, it depends, like everything else. So some kids, even in the office, have trouble playing. And part of the work is to help them kind of learn to play. If you have a kid who can't play, they can't play on the computer maybe even more. So you do often have to involve parents and families, and that changes things, just like it changes when you have a kid who won't come into the office by themselves and you have to be in the office with the kid and their parent. So there are things you learn and you adapt, but it's different. Kids are also very, very physical. So they are, unlike an adult patient, a kid will run into your lap and hug you or spit on you or hit you in a way that, hopefully most adults won't do with us. So working with kids in person brings a whole nother level of risks. Kids are also, now 12 and up are getting vaccinated if they want, but 12 and under, 11 and under are not, and it'll be a while before they will be. Kids are also often physically sick, right? This is the age of colds and flus, and how do you tell the difference? That kid whose nose is running, is that COVID? Is it a cold? what do? Little kids don't really know how to blow their nose or wash their hands or wipe after they go to the bathroom. These are all factors that may sound funny to talk about, but bringing into the office in a COVID way is very different. And something I've learned talking to some people who work with groups, this is something I hadn't considered. Groups are different. So you might have vaccinated group members and unvaccinated group members. If you have an ongoing group, what do you do? How do you decide whether the group can reconvene in person? And the group feeling on Zoom may be very different than the group feeling in the office.
And one thing we have found, I think, is that having some people on Zoom and some in the office is not so good.
Yes.
That's the least effective model of how to work with people. And it's better probably to have everybody on Zoom. But the other thing that reminded me when you were speaking is, since children under 12 are not yet able to get vaccinated, we hope soon, but not yet, then the issue that Gail was bringing up of how do you take care of the contagion question with your other patients if you're seeing those kids and they can't be vaccinated. Or their siblings aren't vaccinated, so that there's really this. On the other hand, the thing, and I know that you've experienced this too, is the amount of inventiveness that therapists have been able to exercise with kids has opened up many ways of working with children that we really hadn't focused on.
Yes,
The incorporation of the computer or the iPhone or whatever into the therapy, and the many apps that now really help us do our work has been really interesting. It really helps.
Necessity truly is the mother of invention, right? And we will never go back to the old way. I mean, that even if everyone is vaccinated, COVID is dead, this will come into the office. There's no going back. You can't put the genie back in the bottle. One other thing I wanted to mention about kids is that, you can have an adult come to the waiting room, come to your office alone. You can't really do that with little kids. 2-year-olds, 5-year-olds are not going to drive over to your office or take the train by themselves. So they often come with a parent or with a nanny or a babysitter or someone. So that adds a whole nother factor to the amount of people in your waiting room.
Yeah, the other thing just to add on is we've talked a little about families. So I think family therapy, analytic family therapy, which I'm very interested in, has worked quite well using distance technology because all these factors can be taken care of. There are parents to support the young children. The play can go on. The parents can tell you what's happening in the play. They can be in the room, or if a child is off at college or whatever, they can be there. So there have been some advantages to this, especially with families who are spread out geographically. We can do things that now I think we can do with comfort, whereas before it was kind of worrying about whether this was legit or not. Well, okay, so I appreciate things that you've had to say. Those of you who are standing by because you don't see children, if there's anything you want to add here. Okay. Yeah, go
The
ahead.
other thing I would add, because you mentioned special populations, is I think we have to be particularly sensitive to the elderly geriatric patient that this past year has reawoken a lot of fears of isolation, loneliness, and death. And they may not talk about it, but I've heard an awful lot.
Yes, well, that's a really important special population, isn't it? The isolation among the elderly that has been devastating, right along with their high rates of contagion, of catching COVID. Well, thank you all for these comments. I think as we've experienced, this opens up a lot to think about. So our final topic is, here we are a year later. How do we as analysts think about our own experience about the pandemic and the mental health issues that are a mental health pandemic, with anxiety, depression, isolation, pandemic trauma, stress experience that affects us as well as our patients. And at the same time, it's relevant to healthcare workers, community settings, everybody, as well as ourselves. So Gail, why don't you lead us off with this?
Thank you. We know as mental health care providers, a couple of things: that we're oversubscribed because there has been this huge influx of people who both have been so taxed this year and either relapsed or became newly symptomatic. And we know that in many, many areas, there are huge waiting lists to see any sort of mental health care provider. We also know, and some of the work was done by the COVID task force of APsaA, looking at post-traumatic stress experience, but the experience of living through and being in and treating, so vicarious trauma, treating people who've had terrible loss this year, financial loss, fear of illness, death of fear of death themselves or a family member, hospitalization. And we also know that healthcare providers as a whole are struggling more with burnout and their mental health than really ever before. I mean, somewhere close to 160,000 healthcare providers have died this year from COVID. And so the early period of being forced really in a way to the expectation, you will take care of these people because that is your job. And being put in dangerous situations without necessarily having protective equipment. So this rise in burnout, I think it meets with a group of professionals like ourselves who, once we're past our own analytic training, don't typically dip back in for treatment, are not necessarily comfortable saying, I think I need care. I think I do need my own care. And so I have a lot of concern, and I think many people have a lot of concern about what is that going to mean for us as practitioners. You know, will we acknowledge we need care? Will we be able to get care when everybody is so oversubscribed? And what will happen in terms of, you know, what people will have PTSD or acute stress reaction and go on to develop real post-traumatic stress disorder, and how many people will resolve.
To add to what Gail was saying, you know, we typically are listening to these difficult things all day, every day, but they're usually different issues. And for the last year and a half, almost all of our patients, this has been the primary concern for them. At the same time, it's been something we've been going through ourselves. And so I think that really does add to the sense of burnout, is the intensity of the need to talk about other people's experience in almost every hour while they're processing something that we're going through ourselves. And so I do think it's so important for therapists to seek their own treatment if they need to. And there's nothing to be ashamed of. I mean, we're carrying a double burden, and it's very important to take care of ourselves.
You know, Jennifer, I agree with you. On the other hand, I want to say that your experience as chairing the peer support network that our committee has put together, hasn't that really gone a long way to supporting people through these issues too?
Yes, and for anyone that doesn't know, APsaA did offer peer support groups for mental health practitioners, and these have been going on for over a year now. And it's been weekly groups with group facilitators who have allowed people to process their feelings, and it has been very effective. And it's something that we were so happy that we could offer to the community, and it has provided a sense of support through every stage of the process. So yes, that is definitely been something that is an important kind of support.
It's a preventive support, really, to prevent the kind of burnout
Exactly.
and isolation. Jeff.
Yeah, Gail, you raised so many important points, and I would just add a couple of things that I've seen in the field working with first responders in the midst of a disaster that have to keep working. And that's what those of us in the mental health field are right now. We have to keep working as though we're immune from what's happening, yet we are them. And very often what we see is a parallel process that while we're helping people in the field, we're not only experiencing the same thing, but we'll often end up mirroring a lot of the things we're hearing, like I can't do enough. It's all useless anyway. Did I choose the right field? Maybe I should do something else. And as David is pointing out, not necessarily going into treatment, but peer consultation, or even just talking to a group of therapists so that you know you're not alone is often very helpful. And one other point, PTSD, what we're seeing in this pandemic experience is a grinding weariness and ennui among our patients and ourselves. And I would caution people, therapists as well as patients, the old Freud admonition, I wouldn't necessarily make major life-changing changes during this pandemic unless it's well evaluated. Because I think a lot of people are thinking about retirement, or I'm going to quit, or I'm major life decisions, and they may not see how it's connected to the pandemic experience.
Yeah, well, this is
Jeff, that's an excellent point. I mean, going back to Gail's point earlier that, we all in a way made one of the most major life changes possible. The whole world made this massive behavioral change to leaving our offices, to going on Zoom. And now the possibility of going back, or the actuality of going back, maybe one of those other life changes that many of us are struggling with, should we keep thinking about it? When do we know to act or to keep thinking? It's a very difficult choice.
One thing that occurs to me as you're talking about this, Dan, is people are making these decisions at very different periods of career development and life development. So I think, okay, we've been concerned in my institute about how do we help people in training make these decisions. Maybe people who've had to start their training without having a patient live in the room with them, which deprives them of an experience we've always thought was fundamental. And for whom then going back to having their patients in the room is very important for their growth and experience. And at the other end of the continuum are those people who are late in their career and may think, well, this is the time I just retire and get rid of this problem. And of course, the bulk of people are kind of in the middle. But I certainly have known people who've given up their offices, as you were talking about earlier. Others who have said, who owned an office suite and said they just weren't going to have anybody else in it to avoid the risk factors we've been talking about. There are all these decisions going on all the time for people. And this phase is going to involve more decisions, more major life decisions. All right. Well, I want to thank you all for coming together to consider these imponderables and the way that we all are facing these uncertainties and trying as best we can to not only deal with it ourselves, but to help our patients and families deal with this. So I want to thank you very much for this very engaging and important conversation.
Thank you for having me.
Thank you.
Thanks
Great
so
experience.